Okay, good morning. My name is Jodi Kagihara, as Dr. Masaki said. I just want to, before I start, thank Dr. Masaki and the organizers for inviting me to speak today. So I will be talking to you about updates in breast cancer. Cancer is the first and second leading cause of death before age 70 in 112 out of 183 countries. And it ranks third and fourth in a further 23 countries. In particular, in 2020, cancer caused almost 18% of all deaths in the United States. And as you can see by the graph here, in those under age 65, it's actually surpassed heart disease as the leading cause of death. In particular, for new cases of breast cancer in the United States, you can see here the darker blue states are those that have higher rates of new diagnoses of breast cancer. And in general, breast cancer is the world's most prevalent cancer. In 2020, 2.3 million were diagnosed with breast cancer, and about 7.8 million women were living with breast cancer and who were diagnosed over the past 5 years. The incidence rates are higher in economically developed regions such as North America, Western Europe, Australia, and New Zealand, and lower in economically developing areas such as Sub-Saharan Africa and parts of Asia. And this is likely related to screening, reproductive factors, fat intake, weight, age of menarche when they start their menstruation and lactation. In the United States, breast cancer is the most common. Thousand men being diagnosed in 2022, and it accounts for 15% of all cancer diagnoses. In general, 1 in 8 women will be diagnosed with breast cancer during their lifetime. Each year, there's an average of over 7,000 Hawaii residents who are diagnosed with invasive cancer. And in 2018, we had over 66,000 residents living in Hawaii with cancer. And of that, breast cancer was the most common diagnosed in women. You can see here breast cancer being most common comprises 34% of cases and over 1,200 new cases per year. And 72% of the breast cancer cases are diagnosed in women over the age of 55. The incidence is higher in Japanese and Native Hawaiian women. And Native Hawaiian women have a higher mortality than Chinese, Filipino, Japanese, white, and other Asian women. Depicted here in the blue and green, most breast cancers are diagnosed at an early stage, about 76%, and then 22 diagnosed at an advanced stage. That's the yellow and pink colors there. Although it's the most common cause of cancer in women, it is also the most common cause of death. However, fortunately, it does seem that the death rate is declining. In 2022, it's estimated that in Hawaii, there's about 1,430 new cases of breast cancer, and that we have 210 deaths related to breast cancer. So risk factors for breast cancer, most important ones are being female and age over 50 years old. Other risk factors are age at first birth, being over the age of 30, starting your menstrual cycles earlier, so younger than 12 years old, and then going into menopause over the age of 55. There are other benign breast conditions that can increase your risk for breast cancer, such as atypical ductal hyperplasia, lobular carcinoma in situ, and certainly family history plays a role here as well. You're at higher risk if you have a first-degree relative who's had a history of breast cancer, or if you are of Ashkenazi Jewish descent. And if you've had radiation to the chest prior to the age of 30, you could be at increased risk for breast cancer as well. In terms of modifiable risk factors, taking exogenous hormones can increase your risk as well. These are things like oral contraceptive pills, estrogen replacement therapy, obesity, lack of exercise, alcohol use, poor diet, and then if you tend to have dense breast tissue on mammogram, also at increased risk of breast cancer. We also have genetic conditions and genetic mutations that are associated with increased risk of breast cancer. I think some of the more or most common ones that we might hear in mainstream media are the BRCA1 and 2 mutations. This is the one that Angelina Jolie had, for instance. And there are also other conditions such as Li-Famini, Cowden syndrome, Peutz-Jeghers, etc., listed here. In particular, if you had a history of breast cancer, you most likely, or your doctor is probably brought up talking about genetic testing. At this point in 2023 now, a lot of times we are sending our patients to get genetic testing. There's a whole list of criteria here, but if you're a young woman less than 50 years old who had breast cancer, you may qualify for genetic testing. If you've had triple-negative breast cancer, you're diagnosed with multiple primary breast cancers, male breast cancer, or family history of breast cancers, including ovarian and prostate and pancreatic cancer, we should talk about genetic testing in those women. For the BRCA1 and 2 mutations, I just wanted to talk about this a little bit. BRCA1 and 2 proteins function as tumor suppressors that protect chromosomal stability, allow for DNA repair. And so when you have a mutation, you are more susceptible to DNA damage and therefore increased risk of breast cancers. This is an autosomal dominant mutation that is passed down. You're at very high risk for breast cancer. In addition, there's also risk of ovarian cancer, pancreatic cancer, and prostate cancer. In males, this also increases your risk for breast cancer. And BRCA1 carriers are more likely to develop triple-negative breast cancer, which is one of our more aggressive types of breast cancer. If you did have a BRCA1 and 2 mutation, we would consider doing bilateral mastectomies or removing breast tissue on both sides, including talking about removing ovaries to try to decrease the chance that you would develop a breast or ovarian cancer, and would also consider screening for pancreatic and in men prostate cancer. Li-Famini syndrome is another genetic condition that could increase your risk for breast cancer. It's due to a mutation in the TP53 gene. This occurs in 1 in 5,000 women, and in patients who have Li-Famini syndrome, the lifetime risk of developing a cancer approaches almost 100%. And 90% of these patients do develop a cancer before the age 60. These cancers are not only breast, but also include sarcomas, brain tumors, adrenocortical carcinomas, and leukemias, blood cancers as well. So there are multiple different risk models that we can use to help determine what our lifetime risk of breast cancer may be. These models look at things like age, when you first started menstruation, the age of your first full-term pregnancy, whether you've had children, the number of breast biopsies you've had to have done in the past, whether you've had some benign changes like atypical hyperplasia in the breast, and then including family history and race. And then talking about mammograms, so screening has shown to decrease the breast cancer mortality by over 30%. And of course, this does vary with age. There are, however, some harms with doing screening. So it can definitely be very anxiety-provoking. We can have false positives, meaning abnormalities found on mammogram that end up being benign changes. So that could lead to unnecessary biopsies, overdiagnosis, and sometimes we find precancers that we treat that may have never turned into or developed into invasive breast cancers to begin with. So there are multiple different, organizations that have screening recommendations, but I wanted to share with you today our sort of national cancer guidelines. So for women of average age risk, annual mammograms and breast exams are recommended starting age 40. In women whose lifetime risks are greater than or equal to 20%, or if they've received radiation to the chest wall between the ages 10 and 30, then we like to start screening earlier. Once we know that this risk is known, then we start screening with mammogram and breast exams. If you've had a family history of breast cancer, then we typically talk to you about starting mammograms 10 years before that family member was diagnosed with breast cancer, no sooner than the age of 30 or by the time you're age 40, whichever comes first. And then if considering also annual MRIs, which we'll talk about, again, starting 10 years prior to the age a family member was diagnosed, not before age 25 or by age 40. There are some things we can do to try to prevent breast cancer. So exercise. At least try to get in 2 to 3 hours per week. And this can really, we have multiple studies that show that this can really decrease the risk of cancer coming back or you getting cancer almost by 40%. Weight loss, avoiding alcohol, smoking, and then if you've had a higher risk of breast cancer or maybe benign changes in the breast, you would also, or you may consider taking medication to decrease your risk of breast cancer. So some of the medicines you might have heard about are things like tamoxifen or anastrozole. So different signs and symptoms concerning for breast cancer. Of course, if you've noticed a new lump in the breast or under the arm, thickening or swelling of part of the breast, irritation or dimpling, redness, flakiness of the skin around the nipple area, nipple inversion or pulling in of the nipple discharge that is other than breast milk, this includes blood. And then any change in size or shape of the breast or pain in any area. Now, certainly these can be a lot of different things, so I don't want to scare you. There are a lot of benign breast conditions that can also cause these changes, but certainly things that we would look out for. If we did notice a mass or something worrisome, we would use mammogram and ultrasound, our imaging techniques, to diagnose whether you truly have breast cancer or not. In some situations, we will use a breast MRI to help us determine if a mammogram is inconclusive or not quite clear, whether there's truly a mass there or not. The problem with breast MRIs and why we don't use it routinely is that we do frequently find abnormalities that are really benign, and so it's common for us to get a false positive. Once the breast cancer is diagnosed, we depend on our pathologist to tell us sort of what kind of breast cancer we have here. Different types of breast cancer behave a little differently. Some can be more aggressive than others. The most common is a ductal carcinoma, then lobular carcinoma, and then here listed below. Once we make the diagnosis, we also stain our biopsy samples for different receptor markers, estrogen receptor, progesterone receptor, and human epidermal growth factor receptor 2, or HER2. This is important because from there we're able to break down the breast cancers into different subtypes. And this is really how we go about deciding on our treatment recommendations for the breast cancer. In particular, we have hormone receptor positive breast cancer. This is the most common type. About 80% of our breast cancers are hormone positive. These are the ones that we find are estrogen or progesterone receptor positive. These breast cancers or these receptors allow the breast cancer to use estrogen to grow. We also have HER2 positive breast cancers. These are the breast cancers that have the human epidermal growth factor receptor overexpression. They may also be estrogen and progesterone receptor positive, so a little bit of overlap here. But HER2 protein can bind to this HER2 receptor on cancer cells and allow those cells to grow. Okay? And then we have triple negative breast cancer. These are our breast cancers that are the estrogen receptor, progesterone receptor, and HER2 receptor negative. These types of breast cancers, unfortunately, can be more aggressive or are more aggressive. Patients who have triple negative breast cancer are at higher risk of cancer coming back someplace else, stage 4, almost up to 30 to 50%, and have a higher risk of breast cancer coming back in the first 3 years after diagnosis. In the graph here, we have our 5-year relative survival rate. Here you can see that in hormone receptor positive breast cancers, they have overall the best 5-year relative survival rate at about 94%, compared to our triple negative breast cancer patients, which would be closer to about 77%. In order to stage our breast cancers, we use the tumor size in the breast as well as lymph nodes, the number of lymph nodes involved, as well as where those lymph nodes are located, and whether there's cancer that has spread someplace beyond the breast and the axilla, such as bone, liver, lung. We will sometimes recommend that we do staging scans, essentially CAT scan and bone scan, to look to see if cancer has spread anywhere else. Sometimes we will also recommend that we get a PET scan. PET scans are similar to CAT scans, but look at something different. They're looking at the metabolic uptake and activity of different tissues in the body. In general, cancer is typically using more energy, and so on a PET scan, it can light up and help us if there's something that's indeterminate on the regular CAT scan and bone scan. So here, just wanted to give a pictorial representation of how we use the primary tumor size as our staging. As you see, the larger the tumor, the higher the T-score, T1 through 4, and T4 is when the tumor is causing changes in the actual skin tissue as well. Here, the red is areas of where there might be cancer. So this is the lymph node staging depicted here, that the more lymph nodes involved, and as we get further and further away from the breast, so involvement of the lymph nodes higher up in the neck or in the middle, closer to the center of the chest, that gets a higher N score. Then we use our national cancer guidelines to kind of plug it in to determine what stage you actually have between stage 1 to stage 4. You can see here we use the T-score, N-score, and then M-score is whether cancer has spread anywhere else. I do want to make a note that there are multiple different staging systems, so it can get a little bit confusing. In particular, our typical standard staging is just based on the T and M scores that I had just spoken to you about. But then we also have prognostic stages that take into account those estrogen, progesterone, and HER2 receptors, in addition to grade or certain characteristics of how the tumor looks like under the microscope. Fortunately, most patients are diagnosed with early stage breast cancer, so breast cancer that's just limited to the breast, about 64% of patients. An additional 29% or almost 30% have cancer that has spread to the lymph nodes at the time of diagnosis. Unfortunately, 6% of patients with cancer that has spread outside of the breast and axilla at the time of diagnosis. And as you would expect, patients who are diagnosed with localized disease do have a better 5-year relative survival compared to those who are diagnosed with stage 4 breast cancer. So when we talk about breast cancer, there's two main types of treatment. There's local treatment and then there's systemic treatment. Local treatment meaning treatment just directed to the breast or under the axilla or under the arm itself. These are things like surgery and radiation. Surgery, or just removing the breast tumor, looking at the lymph nodes underneath the arm. And then there's systemic therapy, or treatment that goes throughout the whole body. In the breast cancer world, these are things like chemotherapy, anti-hormone therapies, and our HER2-targeted therapies. For patients who have localized disease, stage 1 to stage 3, our goal of treatment is cure. So for breast surgeries, there are two main types of surgeries we do for breast cancer patients. One is breast conserving therapy. These are patients in which we feel we can just remove the tumor with a lumpectomy, not having to remove all the breast tissue, and combine that with radiation. And then there's mastectomies, where we remove all of the breast tissue in that area. In general, we feel breast conserving therapy, so a lumpectomy with radiation, compared to mastectomy alone, where we remove all the breast tissue, have equivalent survival. Patients are not always candidates for breast conserving therapy. So some patients who have multiple tumors in the breast, or they have a really large tumor compared to the rest of their breast tissue, may not be candidates for breast conserving therapy. If you've previously had radiation to the chest wall, then it's difficult for us to radiate again, and would likely recommend a mastectomy rather than breast conservation. And women who are pregnant who need to have breast surgery can't get radiation, so again, in that situation, would recommend a mastectomy over a lumpectomy. And then there are some patients where we find more breast cancer there, or more precancerous lesions than we expect at the time of surgery. They end up having what we would call positive margins, or evidence of cancer, where the surgeon made the cut and would have to go back to remove more breast tissue. Depending on how worrisome or how much disease may be there, we again may recommend mastectomy over breast conservation. Those patients who may not be initially candidates for breast conservation, we may consider doing treatment prior to surgery to try to shrink the tumors down so that they can eventually get breast conservation. Surgeons will also want to look at the lymph nodes underneath the arm. This is the most common place for breast cancer to spread to first. Initially, way back when, we used to try to remove all of the lymph nodes under the arm, try to get as big a sample to try to see and make sure we get all of the disease out. Now, though, recently, we've been moving towards trying to be more specific in which lymph nodes we're targeting and which lymph nodes we're removing. And we found that maybe removing the lymph nodes may be of more prognostic value than actual therapeutic value. And so now we look frequently to sentinel lymph nodes. These are the lymph nodes that are most likely to have cancer have spread to them first. So this is based on the thought that tumor cells migrating from the primary tumor in the breast will metastasize to one or a few lymph nodes first before spreading to other lymph nodes. So at the time of surgery, the surgeon will inject a radioactive substance or a dye near the breast tumor. That dye will travel to lymph nodes under the axilla. They'll be able to identify which lymph nodes these are and remove those lymph nodes, look at those first to see if cancer has spread to those areas. This is called a sentinel lymph node biopsy. So in patients who present to our oncologists and our surgeons, and we can't find or don't suspect that cancer has already spread to the lymph nodes, we will typically talk to them about doing this sentinel lymph node biopsy, more targeted. Let's look at these lymph nodes that are most likely to have cancer first. However, in patients who we know already have cancer that spread to the lymph node based on biopsy or what we can tell on exam, we may be talking more about removing more lymph nodes than just the sentinel lymph nodes. Radiation therapy is typically done after surgery. and is recommended for most patients who have breast conservation surgery, so that lumpectomy that we were talking about. The benefits of radiation are that it can decrease risk of cancer coming back in the breast and in the axilla, in those lymph nodes, and also decrease the risk of breast cancer-related deaths. Of course, again, this varies based on age, the type of breast cancer that you have, whether you're also taking medicines to decrease your risk of cancer coming back. Traditionally, radiation is given over a 5 to 6 week time frame, Monday through Friday. You get the weekends and holidays off. And then more recently, we've been able to look at shortened courses of radiation, so 3 weeks, and now maybe even 5 days of radiation. In some of our older patients with very favorable tumor characteristics, the radiation oncologist may talk to you about omitting radiation and whether it's truly necessary or not. Side effects with radiation include fatigue, skin irritation. I tell patients it can kind of be like a bad sunburn. If you've had that before, with the itchiness, redness, overall peeling of the skin. You can also get breast swelling. It can also contribute to lymphedema or increased risk of swelling of the arm. And certainly if you have an implant in that area, damage to the implant, increased risk of rib fractures or cause chest wall tenderness. Depending on how the radiation beams are directed, it may also sometimes get some of the healthy lung tissue or part of the heart tissue. We do our best to try to avoid those areas, but sometimes you can also get damage to those areas as well, and can also increase your risk for some secondary cancers. So systemic therapy, meaning, again, treatment that goes throughout the whole body. Unfortunately, we know that breast cancer is a type of cancer that could spread someplace else, right? So even if you've had localized disease, it's not gone anywhere, we worry, could there be a cancer cell floating around somewhere? It could set up shop in the bone, liver, lung, and over time continue to grow. If it continues to grow to become a problem, that then becomes a stage 4 breast cancer, which, although is treatable, is not something we think we can cure in 2023, and so definitely a situation we want to avoid. So this is where the systemic therapy comes into play, almost a sweep, if you will, to try to get rid of any of these rogue cancer cells that might have gone someplace else to try to prevent breast cancer from coming back further down the line. In the breast cancer world, these are things like chemotherapies, anti-hormone therapies, and HER2-targeted therapies. So chemotherapy can sometimes be given prior to our surgery, like I was talking about. These courses of chemotherapy can be 3 to 5 months long, and the reason why we may consider giving it prior to surgery would be to decrease the tumor size, shrink it down, make it easier for the surgeon to resect so that you may be able to have a lumpectomy rather than having to have all of the breast tissue removed. And then also in our more aggressive breast cancers, like our HER2 positive or triple negative breast cancers, it can be prognostic. So we can look at how well your cancer responds to the chemotherapy and HER2 targeted therapy, and therefore change our treatment recommendations as we go forward. Side effects with chemotherapy, certainly I'm sure you have some pictures in your mind. Fatigue, nausea, vomiting, diarrhea, constipation, decreasing blood counts, white cells, red cells, platelets, mouth sores, hair loss, numbness, tingling in the hands and feet. Certainly all these are very real, but we do have a lot of medicines that are much better than they have been in the past, and so typically are able to do a better job of supporting you through these adverse effects if you were to need chemotherapy. Anti-hormone or anti-endocrine therapies work by decreasing estrogen or directly targeting the estrogen receptors. These are medicines, again, like tamoxifen, anastrozole, fulvestrant, and these side effects are similar to going through menopause. So hot flashes, joint aches, mood swings, vaginal dryness, all the things, we potentially if not have experience, will experience going forward. In the long run, this also can cause a decrease in bone density, so we're often monitoring bone density over time. Our HER2-targeted therapies block the HER2 receptor from receiving the growth signaling. They're typically given in combination with chemotherapy. And side effects with these medications are typically more like diarrhea, nausea, vomiting, fatigue, and it can cause heart damage that fortunately is typically reversible. So in general, for our hormone receptor positive breast cancers, as I had mentioned, we determine our treatment based on sort of the subtype of breast cancer that you have. We typically are talking about doing surgery first. After surgery, there may be a question about whether to do chemotherapy or not. If you've had more disease or disease that spread to the lymph nodes, we would consider talking about chemotherapy. We can also run special tests looking specifically at your tumor, the gene characteristics that will help us determine whether chemotherapy will work or not. As well as consideration of radiation if you've had a lumpectomy or cancer has gone to the lymph nodes. And then absolutely be talking to you about taking anti-endocrine therapy with a goal of at least 5 to 10 years. For HER2-positive breast cancers, if small tumors, then we'll typically recommend surgery first, but it's not uncommon now that we're heading more towards doing chemotherapy or HER2-targeted therapy prior to surgery, again, because this may change our treatment recommendations going forward. Say if you didn't have as great a response to that treatment as we would have liked. In addition, would consider radiation. And then in our triple-negative breast cancer patients, again, with the triple-negative breast cancer being more aggressive, oftentimes we are talking about chemotherapy first. If really small tumors, then may just talk about doing surgery followed by chemotherapy. In this situation, we don't have the hormone therapies or the HER2-targeted therapies to use to try to decrease risk of recurrence. So unfortunately, that means we're left with our chemotherapies to try to decrease the risk of cancer coming back. After treatment, breast cancer patients are put on surveillance. We have the patients see us between 1 to 4 times a year, and then eventually that becomes an annual follow-up with annual breast exams, and an annual mammogram was recommended. In the absence of any signs or symptoms worrisome that cancer is going to come back, we don't have any routine laboratory testing or CAT scans that we recommend on a regular basis to follow. For patients who have metastatic or stage 4 breast cancer that's spread somewhere outside of the breast and under the arm, again, places like bone, liver, lung, unfortunately, the median overall survival is only slightly over 3 years. Now, this does, again, vary based on the subtype of breast cancer that you have, hormone positive, HER2 positive, or triple negative. Unfortunately, our triple negative breast cancers do have a lower 5-year relative survival compared to those who have hormone positive or HER2 positive breast cancers. Patients with stage 4 breast cancer, as I mentioned, are unlikely to be cured, and so the goal of treatment in this situation is to prolong survival as long as we can, but also to alleviate any symptoms you might be having from the breast cancer. Not only just to maintain the quality of life, but even to improve the quality of life if possible, while trying to balance the toxicities of our treatments. Again, treatment will vary based on the subtype of breast cancer that you have. For example, in our hormone-positive breast cancer patients, we do have those anti-endocrine or anti-hormone therapies that we can use to control breast cancer. We then also have more targeted therapy options before needing to go to chemotherapies to try to control disease. In our HER2-positive breast cancer patients, we are typically always using some kind of HER2-targeted medication, if possible, to try to control the cancer, and typically these are combined with chemotherapy drugs. And again, for a triple-negative breast cancer, limited to some of our chemotherapy options. this is the only situation or setting in breast cancer where we have the option to potentially use immunotherapy. So I want to leave on a very positive note. There's tons of research being done in breast cancer, and I would say there are multiple new drug approvals every year, different options that we can try to use to get better control and improve the outcomes in our breast cancer patients. These are more targeted therapies, so typically therapies that may have less side effects than what we're used to thinking. In patients who have different mutations, we can target those mutations, like the BRCA1 and 2 mutations, for example. We are getting more specialized in how we're able to deliver our chemotherapy. So we have these antibody drug conjugates. That's in this picture here. It is we're able to bind chemotherapy to this protein or antibody that is then targeted to cancer cells, but breast cancer cells, and can deliver the chemotherapy directly to those cancer cells rather than sort of chemo going just everywhere throughout the body. This is sort of a fancier way to deliver the chemo. In that situation, we can get around some of those traditional side effects that we know of from chemo. And then immunotherapy that I mentioned. So in general, immunotherapy is sort of stimulating your immune system to recognize the cancer as being foreign and to recognize it as something that your own immune system should get rid of. And so sort of trying to use the mechanisms that you have naturally to try to get rid of cancer cells. And we're also looking at vaccines. This is just a short list. We have many other options, and it's actually a very exciting time. So I will end with that. Thank you for listening, and I will take any questions.
Jodi, thank you for a wonderful presentation. So we'll first start with questions from our in-person audience.
Mahalo for your talk. I'm a breast cancer survivor and thriver, and I have two questions. One is, why is genetic screening focused on only under 50? What about those that are over? And then also, do you advise your patients to see a dermatologist each year after radiation, because skin cancers are very common after that process?
Yeah, so I'm sorry, can I go back on the slides?
Yeah, you can.
Well, so I did kind of focus on women less than age 50, but we also are looking at women over age 50, depending on certain characteristics. If they have triple negative breast cancer, regardless of age, we recommend genetic testing. And looking at family history, if you've had multiple breast cancers, et cetera, that's sort of regardless of age. But because breast cancer can just be more common in women over 50, it's not recommended that we just test everybody at this point. I will say, though, that the indications are increasing, so we are almost getting to the point where almost everybody may be able to get genetic testing. I'd say in real world practice, the limitation here seems to be insurance companies and whether they'll allow us to get that approved. And then for your second question, dermatology. So as a medical oncologist, I'm frequently doing breast exams for follow-up every 3 to 4 months, and that gets spaced out. I do not always recommend dermatology evaluation for all of my patients, but certainly if there are suspicious findings, I do like to get dermatologists involved or look into different skin changes further.
Thank you. Let's start with the online. So there's one question, actually there are two questions that are kind of related. So the first one is, does breastfeeding lower the risk of breast cancer? And the second one is, does giving birth decrease the risk of breast cancer?
Okay, so breast screening, does it?
Breastfeeding.
Oh, breastfeeding.
Yes.
Does it increase the
risk?
Does
it decrease the risk?
Decrease the risk. I actually don't know the specific numbers for breastfeeding, but having a child at a later age can increase your risk of breast cancer. So having a child then in general, I would say decreases the risk.
Okay, great. Any more in-person questions?
I was wondering why the term extremely dense mammographic tissue is considered modifiable. Is there something a person who has that can do to make it less dense?
Yeah, I kind of thought about that as well. I think the way that they were looking, at least in specifically that table, may be related to age, which again is not totally modifiable. Certainly, maybe body habits could play a role as well. But we typically think women who are younger have more dense tissue compared to women who are older. So I'm not sure if that's why it was kind of listed in the table there. But I did have a similar thought.
Are there any novel therapies that are available here in Hawaii?
Oh, yes, absolutely. So, yes, the answer is yes.
Okay, great. Any other questions from the in-person audience?
I was diagnosed in 1982, way before all of this. I was ER positive, which they knew was good. I was PR positive, but they had no idea what that meant, if that was good or bad. And of course, HER was not in existence. Is it too late for me to find out if my cancer was HER positive or negative?
Oh, I guess that would depend on whether the biopsy and surgical sample are still available for testing and whether they think they have enough good viable, like the pathologist feels they have good viable tissue that they could test. But I would say at this point, it's really great news that you're doing well, and so I would not worry about it. Yeah.
If you've had a bilateral mastectomy, do you need to have any tests or screening after?
Yes, a good question. So for patients who've had bilateral mastectomies, we don't recommend any additional imaging. So that would be mammogram, ultrasound, or MRI. But you would still follow with your physicians doing chest wall exams, feeling for any lumps or bumps or anything worrisome.
Any other in-person questions? There are a couple more here. Is there an age limit to stop doing mammograms?
Also a good question,
Yeah, very good question.
What I tell patients is that if we were to find a breast cancer on mammogram, would you still be interested in having surgery or having treatment for that cancer? And if the answer is yes, then I would consider still getting your mammograms and doing your screening. If the answer is no, I would, not want to have surgery at this point in my life or take medications to treat it, then I would say those are the patients who, would consider not continuing with screening.
Okay, great.
I got another question. I have heard that in Canada, they have stopped recommending screening mammograms. Have you heard that?
I actually have not, but I just don't know if that's true. Yeah.
There's a question about, is there an alternate to doing a mammogram for somebody with a very low pain tolerance?
Yeah. So mammograms, we really try if we can, but I would say that's where maybe the ultrasound or the breast MRI might come in. We have to, though, keep in mind that the mammogram can find things that an ultrasound or an MRI may not be able to find, and vice versa. So it doesn't quite, there's no equivalent replacement for a mammogram, at least at this time.
I mean, I think all of us agree it's not one of our most fond experiences. On the other hand, it is pretty quick. Thank goodness for that. It's just as you feel like, oh my God, it's over. So that's the good thing. There's another question about the giving birth. So having children when a woman is older, and what age is that, increases your risk. if you have children at a younger age, and what age would that be, does it decrease your risk?
Yeah, so it's not quite so discrete in terms of age cutoffs. I would say it's more of a linear risk. And so those, I had kind of listed some risk calculators that we can use, the Gale risk model, for example, that can estimate for us what our lifetime risk of breast cancer is. And you can put in all different kinds of numbers there. But yeah, so no specific age cutoffs that I would say.
Okay, that's very helpful. Any other questions here? Okay, if not, please join me in thanking Jodi for a wonderful presentation.
Thank you.